Hello, students. Welcome to a very important topic of infectious diseases, malaria, its treatment in children, and the national guidelines that have been given. So, we all know malaria is caused by an organism called as Plasmodium, and there are various species of Plasmodium. What are the species that we know of? Plasmodium vivax, Plasmodium falciparum, Plasmodium malariae, Plasmodium ovale, and Plasmodium. Now, let's see. So, vivax is the most common infection that occurs, and the symptoms that happens with Plasmodium vivax are relatively lesser. However, Plasmodium falciparum is known to cause severe complicated malaria, and there is also a risk of cerebral malaria risk with Plasmodium falciparum. There may be a mixed infection where both Plasmodium vivax and falciparum infect the child. It's called a mixed infection, and the symptoms may be very severe. What is complicated malaria? Complicated malaria is when the child presents with um, symptoms like seizures, then there may be shock, hypotension, there may be bleeding manifestations, there may be respiratory distress, there may be altered sensorium. All of these are constituted to be a complicated malaria, and these children require inpatient care. So, diagnostic protocol, how will you diagnose that this particular child has malaria? If a child comes to you with fever and then there are other symptoms, what are the symptoms of malaria? The child has fever, he may be lethargic. In complicated malaria, there may be bleeding manifestations, there may be seizures. But normally, if the child has uncomplicated malaria, they normally presents with just fever and a lot of lethargy. Sometimes there may be icterus as well, right? So what is the diagnostic protocol? How do you diagnose? The gold standard is peripheral smear. What you do is you take a drop of blood, you put it on the slide, and you prepare two kinds of smears. Now these two kinds of smears are a thick smear and a thin smear. Okay, so in your thick smear, you see if there is Plasmodium species present. So this sample is taken at the rise of the fever. That means during the febrile phase, you take a sample of a patient, put it on a slide, make a thick smear and a thin smear. In your thick smear, you see if at all there is any Plasmodium species. And in your thin smear, you diagnose or you check which species it is and what is the parasitic index. That means how much of the parasite has lysed RBCs or how much of the patient RBCs are infected with Plasmodium species. Understood? So thick smear and thin smear concept. Then rapid diagnostic test, there are these small kits that are available wherein you can put the serum sample of the patient and then you immediately find out if they have been infected with malaria or not. And these tests, they help you identify if this patient has malaria or not, identify the species, severity. You can also identify it on the basis of complicated and uncomplicated. Now, if you see that the species is falciparum, you can be prepared for a more severe kind of a malaria, right? So that is it's very important. And then region, there are regions that are chloroquine sensitive, and then there are regions that are chloroquine resistant. Right? So typically, your northeastern states are considered to be chloroquine resistant. Okay, so understand that Plasmodium falciparum is known to cause severe malaria, and it is mostly seen in areas with a lot of forests, your tribal regions, northeastern regions, eastern part of the countries. Odisha is known to have a lot of Plasmodium falciparum. West Bengal is known to have a lot of Plasmodium falciparum. And the symptoms are definitely more severe. However, in your suburbans or urban areas, you see a lot of Plasmodium vivax. Okay. And the symptoms are less severe. Okay. So falciparum, you will see a lot in your tribal areas where there's a lot of forest, there's a lot of water. It's not like you do not see falciparum in Mumbai. Nowadays, so a lot of falciparum you see in Mumbai as well. But it's mostly in your tribal areas, hilly areas, and forest regions, right? So understand that you should also know which drugs will work where. Malaria is such disease where you should be very acquainted with the protocol of the treatment that they are following in that region. Okay, what is the treatment guidelines that have been given? What is NVB DCP? It is your National Vector Borne Disease Control Program. Okay, so this has been given by the government, and there is a set protocol. These protocols change if at all they see a change in the pattern of the species. Okay, so Plasmodium vivax, what is usually given in a dose of 25 mg per kg, chloroquine is given for 3 days, and primaquine is given for 14 days. Okay, so you give chloroquine for 3 days, plus primaquine is only given after G6PD is done. If they're not deficient, you start primaquine, and it is given in children more than 1 year of age. So chloroquine for 3 days, primaquine has to be given for a complete dose of 14 days. If it is falciparum is normally considered to be chloroquine resistant. So you start artemisinin-based combination therapy, wherein you either give artesunate plus sulfadoxine pyrimethamine into 3 days and a single dose of primaquine, or you can also give AL. Okay, so here they've given us artesunate, sulfadoxine pyrimethamine, or you can also use artesunate lumefantrine. So instead of sulfadoxine pyrimethamine, a lot of artesunate lumefantrine is also being used, and you give it for 3 days. If there is a mixed infection, you will always obviously have to treat it like Plasmodium falciparum. So you give ACT-based therapy with sulfadoxine pyrimethamine into 3 days, plus your primaquine single dose. Now, this mixed infection in Plasmodium falciparum, the treatment I've told you, it is for malaria which is uncomplicated. If it is a complicated malaria, you give IV artesunate. So IV artesunate has to be given. It has to be given at a 0 hours, a 12 hours, and a 24 hours. There is a specific dosage for it, and it has to be given accordingly. Once the child is able to take orally and symptoms have subsided, you can switch to oral ACT. Otherwise, in a child where you see there is complicated malaria, IV artesunate is the drug to be given. And one primaquine single dose. Pediatric dosing, they've given us dosages also. Sorry, I had said 25 mg per kg. That's for primaquine. It's 0.25 mg per kg per day for 14 days when you're giving for Vivax. Chloroquine is 10 mg per kg first day, second day 10 mg per kg, and third day you give a 5 mg per kg. So the total is 25 mg per kg. Okay, so 10, 10, 5 is how you give. You can give it as 0, 12, 24, but the best way to give it is day 2, 1, 2, 3, 10, 10, 5. Primaquine 0.25 mg per kg per day for 14 days. When you're giving artesunate, so IV doses 2.4 mg per kg given at 0 hours, 12 hours, and 24 hours, and then once daily. Okay, so first in the beginning, 2.4 mg per kg. So if there is a child whose weight is 10 kgs, how much will you get? 24 mg. There is an injection that you get. Okay, and it normally is given with soda bicarb. Okay, so you give 2.4 mg per kg, you give it as 0 hours, 12 hours, 24 hours, and then you give it once daily. Once the child is able to accept orally, switch from IV to oral. Okay. Now, before you start primaquine in any patient, you always do a G6PD, that is glucose 6 phosphate dehydrogenase test. If there is a deficiency of G6B, and you will see it more often than not, if there is a deficiency, do not start primaquine because that drug is known to trigger your G6PD deficiency and cause hemolysis. So there are weight bands also. When you start ACT, it comes as a syrup also. Okay. So there is a syrup called as Lumerax, and there is a weight band also. So 10 to 15 kgs, you give this much, 15 to 20, you give this much. That is also a good table. It is given behind the bottle of the syrup, and you can follow that. Severe malaria, complicated malaria, how do you manage? This is always an inpatient management. You admit them, you start IV artesunate, or IV quinine is also still used in a few patients. But we all know that quinine comes with a lot of side effects. So IV artesunate is the preferred drug. Supportive care in forms of fluids are given. Okay, you give IV fluids, you give antipyretics. Anticonvulsants is given here, but it is only given if the child has had seizures. Okay, if you see seizures in a child, then you start anticonvulsant only then. Monitor for complications, monitor sensorium religiously, monitor urine output religiously, monitor for any bleeding manifestations religiously, monitor that there is no metabolic acidosis in the blood. Okay, so your lactates shouldn't rise. What happens is that, see, in malaria, what is the basic issue? Plasmodium basically infects the RBC. RBC will eventually lie, releasing lactates. There is increase in bilirubin and increase in lactates. So there is a fall in pH of the body. Okay, that will cause altered sensorium and all these issues. So a blood gas is also good if you see a child with altered sensorium. If you see a child with altered sensorium, start and you have a positive malaria, treat it as falciparum, start IV artesunate, do a blood gas. Okay, secure your ABC. That is very important. And give fluids religiously. Also, another thing that you will see on your CBC is that the platelets may be low. So they may require platelet transfusion as well. Do a creatinine, they may go into AKI. So that is important. You have to hydrate really well. Okay. And why anemia? So what happens is that basically hemolysis is happening, right? So your RBCs are getting lysed and hence HB falls. If you check your clinically, you will get liver in malaria hepatitis and there may be a spleen as well. Okay, so then, so typically a child with fever looking trick, there is a liver, there is a spleen as well, malaria endemic region. Please think of malaria and do a rapid diagnostic test immediately. The government has made it so easy for us. We get rapid diagnostic tests even at PHCs, at smaller centers where you can immediately get a malaria test done. Okay, so it's a simple test, it's a cheap test. Don't let it go. Because here, this is not like a viral illness where you will give your supportive medication like fluids and paracetamol and everything will be all right in a few days. This requires a certain treatment. So do not miss out on malaria. Malaria should always be in the back of your head when you're practicing in India, right? OPD versus IPD management. OPD, normally you see a lot of uncomplicated cases. They can be treated orally, and you can do a daily follow-up. A CBC regularly can be done to check for any platelet uh, low platelet count. In IPD, you have to admit them and they're treated as per their symptoms. Falciparum has to be, if there is a child, or they're saying that if there is a young child less than 5 years, please admit them in the IPD, even if it is uncomplicated falciparum. Vomiting, seizures, altered sensorium, all bad signs, admit them. Incomplete response to oral treatment, admit them to give IV treatment, IV therapy. Summary, so use rapid diagnostic tests or smear for accurate diagnosis. Right. Follow your national vector-borne disease control guidelines for age and region, and these keep changing. So you can go through them. Use your ACT, that is your artemisinin combination therapy for falciparum malaria. Primaquine needed to prevent relapse. Why do you use primaquine? So many kids ask, why are we using primaquine? Because your malaria shouldn't relapse. That is why 14 days in Vivax and one-time dose in falciparum. Always assess for G6PD status before starting Primark. That is very important. That is